well. And basically, his doctors also, they took him in and started, everything on day one. So I think that was the prime, care for him, because he got remdesivir, he got toxicillozumab, dexamethasone, and within 10 days he started getting better, and 14 days he was home. So my father was also telling that he never thought that, he saw, when this Second World War was there, he was 10, 15 years old, 10, I think 15 years old, yeah. And he was telling, he thought that that is the worst world can have any calamity and he is not going to see anything. But he also saw that thing. So let's see.
Yeah.
Right. So this is life, yeah. So you are expecting still 30 participants, inshallah, or less than that, or more than that?
We have now 15, 14, so including me and you, so 12.
Yeah, yeah. Dr. Fahim also, I think, has, forwarded the link to, I don't know today because I could not talk to him for today, but last week he forwarded to other groups in Iraq as well. I don't know whether anybody.
Yeah, he has students in Najaf and Karbala. So he asked me again for the link. I sent him again for today.
Okay. Oh, you have sent him. Oh, that's very good.
But unfortunately, our students, they need a reminder every single hour. Like to tell them, like they don't have a diary to write what they have in like 7 o'clock or to come in time. They need a diary.
Well, very typical, of our culture, basically, unfortunately.
Like,
Mhm.
inshallah, with the time, they will learn
Yeah,
something.
yeah, of course. We always should hope for the best, and inshallah, things will come up. And
Mm.
Allah is also there to look after all of us, so
Mm.
things will improve.
So, for better engaging, will you open this week a camera or you prefer without?
No, no, no. I can. Sorry. I'm not good in the gadgets actually, so I'm sorry about that.
It's
I will.
okay, like,
Yeah, yeah. Sorry. How are you?
but usually, like, you open it and then it freeze. Now
Oh,
it freeze. I think you close it or what you do after
no, no,
opening.
no. It's not. I didn't close. It's.
Oh,
Let me do it once more. How is that now?
so just take took a picture, then it also freeze.
Yeah, I really don't know why it is. Perhaps I will use. Actually, I'm using the laptop. Next time, I will use desktops to see whether there is anything.
Okay.
But this is something odd which I'm observing. I don't know why. Because when I did, you know, before you guys last week, I did some teaching session for Pakistani students, and it was all right at that time. I don't know. Maybe some issue with the link or something. I'm not sure, but let's see. Is it still? Is it still? Yeah, it looks like it's still freeze.
Still freezed. Yeah. Like come a picture, then it freeze.
Yeah,
Mm.
don't know really.
So,
I will try
uh,
once more.
yeah,
Let's see.
you may join, like start Bismillah if you like.
Okay, I will just try video once more. If not, then I will just start here. Okay. Right. So yeah, thanks. I welcome all of you for this meeting, and we will start where we finished last time. So this time today we are going to discuss cardiac arrhythmias, and inshallah, if we manage to get hold of some time, then we'll go ahead with the heart blocks as well. And we will rest of the bits we will do next Saturday, and inshallah we will finish and then we take the thing further from there. Hopefully this session will also be helpful for all of you. So let's start with, so we have discussed how we are going to interpret the ECGs in depth last session. So today we are just going to talk about heart rhythms and this arrhythmias or dysrhythmias, So first of all, you need to decide whether the rhythm is regular or not. If the basic rhythm is from the SA node, that is P wave is present or not, and every P wave is preceded is followed by a QRS complex, and the PR interval is within normal range and stable throughout the rhythm strip. If there is no P wave, then it could be the pacemaker is from the AV node or something, or one of the pacemakers around that, and there may be if the pacemaker is nodal or AV nodal or junctional, then there may be no P wave, there may be inverted P wave. So it all depends on where the pacemaker sits. And usually, if it is junctional rhythm, the QRS complex will be normal as sinus rhythm, and if it is broad QRS complex, then it will be ventricular rhythm, which we'll discuss later. So if the rhythm is regular, it could be sinus, it could be junctional, it could be atrial flutter, where you will see some sawtooth appearance. It will be fast, but there will be some blocks, and usually heart rate is around 150 beats per minute. It can be supraventricular tachycardia, which earlier we used to call paroxysmal atrial tachycardia, but now they call it supraventricular tachycardia. The heart rate is quite fast, anything between 150 to 200 beats per minute. If it is irregular, it could be atrial fibrillation. Right. So when we talk about the dysrhythmias, we have to look into either it is faster heart rate or slower heart rate. Right. So this is a very good algorithm about how we classify the tachycardias. It could be atrial or it could be ventricular. Atrial tachycardias are usually not life-threatening, and they can be controlled. Sometimes just watchful waiting and observation is more than enough. So when it comes to atrial faster heart rates, it could be regular, which I already mentioned. It can be supraventricular tachycardia or atrial flutter, or if it is irregular, then atrial fibrillation. Well, the ventricular tachycardia can be ventricular tachycardia, ventricular fibrillation, or it can be Torsades D points, which of course we are going to show as much ECGs as possible. Right. So, and when we talk about bradycardia, which is the heart rate more than 60 per minute, it could be sinus bradycardia when the sinus is either firing at a slower rate or there's a delay at the AV junction and the SA node discharge is basically slow down at the AV node and then transmitted to the ventricles, causing sinus bradycardia. There can be sick sinus syndrome, which is basically the SA node dysfunction, and SA nodes are not properly functioning. It can cause bradycardia. It can cause arrest, sinus arrest or block, or there can be tachy-brady syndrome where there will be transient tachycardia followed by bradycardia. And if the patient is having sick sinus syndrome, then they basically need pacemaker insertion at some stage as soon as possible. Then it could be second or third degree AV blocks, or it could be complete heart block, which is also called third degree heart block. So when there is bradycardia or heart blocks, there can be escape rhythms, which basically is a type of safety net for the heart. Because if for some reason SA node is not working properly or AV node is totally blocked, then the current is not traveling from atrium to the ventricle, and there may be standstill or asystole. So God has given heart the capability to start discharging current from the lower pacemakers, which can be from the bundle of hairs, or even the Purkinje fibers. And of course, then conformation will be slightly different. And of course, when the escape rhythms are there, heart will beat at a slower rate, but there will be cardiac output looking after the patient's needs. The bradycardia can be because of the many medication, mainly the negative chronotropic agents like beta blocker, calcium channel blocker. It can be because of the digoxins, and certain antiarrhythmic medications can also cause bradycardia. And of course, certain systemic disorders, for example, the electrolyte imbalance also at times, especially the hypokalemia and hyperkalemia, both can cause bradycardia. These are the presentation of any patient with bradycardia. He may be having dizziness, syncopal attacks, recurrent falls. He may feel tired and lethargic. There can be chest pain or shortness of breath. Of course, thumping of the heartbeat and palpitation may be there. When you examine the patient, there may be low blood pressure, signs of heart failure, and poor perfusion. When you want to investigate the patient with bradycardia, of course, as I mentioned, UNEs are one of the most important thing. Thyroid function test is also important. And of course, patient need to have prolonged Holter's monitor in order to look into the rhythm and then plan the thing further from there. Right, so this is one of the ECG, which is showing, let's see, the P wave is there and QRS complex is narrow within acceptable range. Yet, as I mentioned before, it need to be with less than 3 small squares. So P wave is normal, PR interval is normal, QRS complex is not widened, it is less than 3 small squares, and followed by normal ST segment and T wave. So this is basically sinus bradycardia, and axis is, if you remember the double thumb sign, both the thumbs are up, indicating that the cardiac axis is normal. If you have a look on the chest leads, if you remember, I mentioned that from V1, you will find very tiny R wave followed by deep S wave, and slowly and gradually there will be progressive prolongation of the R wave. And of course, V1 on the lateral side, which is V1, V5, V6, the R will be quite tall. But in this, the ECG strip, you can see the from the very beginning, the R wave is quite prominent. Most likely it is posterior wall MI. The best way to look into the posterior wall MI is they call it mirror image. You just hold the ECG strip upward, opposite in front of the mirror, from and change it to up 360 degree up, and hold it in front of the mirror, and you will notice that you will see that there will be Q wave and ST segment because you are holding it upside down. So this is the easy way mirror image picture, and that will give you a fairly good idea of whether the patient is having the posterior wall MI or not. Perhaps I will show you some ECGs on next week of all the ischemic changes. So this is another ECG with the sinus bradycardia. P wave is there, normal QRS complex. PR interval is within acceptable range. There is very nice example of progressive prolongation of the R wave in the chest leads, and this is practically normal ECG with sinus bradycardia. While if you go back to the previous ECG, you can see, you can compare the R wave in the anterior chest leads. This is more taller here compared to the second ECG. Most likely that was posterior wall MI, resulting in sinus bradycardia. All right, this is another ECG strip with the sinus bradycardia. Sorry, it's not sinus bradycardia. I can't see any P wave here. So yeah, so this is basically junction rhythm with sinus bradycardia. There's a history here. The 48 years old lady presented with lightheadedness, and she was recently being started on a new medication for the hypertension. So most likely it could be either the beta blocker or the calcium channel blocker, which is diltiazem or verapamil, or beta blocker may be bisoprolol or etinolol. So this is basically drug-induced AV junctional rhythm with sinus bradycardia. With the bradycardia. So this is that what I mentioned. This is junction rhythm, and it's again the same ECG, right? So the heart rate is around 40. There is no P wave, and this narrow complex QRS complexes, and of course the rhythm is regular. Right. This is another example of AV junction rhythm. There is no P wave. QRS complexes are narrow and within acceptable range. T wave is upright. So this is AV junction rhythm. The heart rate is quite slow. Right. So if you talk about tachycardia, of course you are aware that heartbeat more than 100 per minute is tachycardia. We mentioned earlier it could be narrow complex tachycardia or broad complex depending on how the QRS complex width is. If it is less than 3 small squares, this is narrow complex. More than 3 small squares, then broad complex tachycardia. So narrow complex tachycardia are always from atrium or supraventricular in origin. It could be sinus tachycardia, it could be fibrillation or flutter. Right, so this is an excellent example of an ECG. If you see the rhythm is, this is the rhythm is stiff lead 2, and you see RR interval is perfectly regular, and you can't see any P wave here. But of course, if the patient is having tachycardia, appreciation of the P wave is next to impossible. And of course, there is no sign of any flutter or fibrillation. So this is narrow complex tachycardia. Heart rate is 1 to 2, smallest 2 squares. So 2 divided by 300 is 150. So heart rate is 150 beat per minute, which is regular rhythm. And P wave is not there, but most likely it is supraventricular tachycardia. If you see in the lead, most of the lead like lead 2 here, you can see slight slurring in the ST segment. Most likely the P wave is embedded here, but it's difficult to say. So for practical purposes, this is supraventricular tachycardia with heart rate of 150 beat per minute. If you look into the anterior chest lead, you will see that in the lateral leads, the R wave is very, very tall. So 5, 10, 15, 20, 25 plus 10 here. So this is basically indicating left ventricular hypertrophy as well, and the cardiac axis is normal. So this is supraventricular tachycardia, heart rate of 150 beat per minute, and there is some changes suggestive of left ventricular hypertrophy. Right, this is another ECG showing tachycardia. Here you can see if this is the lead 2 rhythm strip, you can see normal P waves, and the PP interval is normal, the RR interval is normal, PR is within acceptable range, QRS is normal, narrow complex. So this is sinus tachycardia. The axis, if you see lead 1 is upright, lead AVF is down. So by double thumb rule, this is left axis deviation. If you look into the anterior chest leads, you can see M pattern or RSR in lead V1. The QRS complex is broad bizarre. The T wave is in the opposite direction to the QRS complex, indicating that this is right bundle branch block. So this is sinus tachycardia with right bundle branch block, and the axis is left. So most likely this is left anterior hemiblock of the left bundle as well. So for practical purposes, this is right. This is the bifascicular block, which we will discuss hopefully later today or next week. This is another tachycardiac ECG. Again, there is hardly any P wave, and the heart rate is 150 beat per minute. Right, this is another ECG. And if you see here, the rhythm is regular. There is the RR interval is equidistant. So this is basically the right. This is basically the tachycardia with no P. It's difficult to say whether this is the P or this is the T wave. So most likely this is supraventricular tachycardia. I can't see any P wave. This is the T wave, I believe. So this is the supraventricular tachycardia with heart rate is around 150 beat per minute. The axis is normal. The anterior chest leads are looking okay to me. So this is just the sinus. Sorry, this is the supraventricular tachycardia. Right, another ECG. This time you can see the P wave, QRS complex. The PR interval is normal, axis is normal. The anterior chest lead, again, RSR pattern, indicating that patient is having right axis deviation. But sorry, see, right bundle branch block, but the axis is normal. So this is sinus tachycardia with right bundle branch block. There is no other changes suggestive of any sinister feature. Right, so this another rhythm strip, and yeah, this is a very excellent ECG. If you see the right, the lead 2, which is the rhythm strip, you can see the RR interval is quite variable. They are not regular. QRS complexes are within normal shape, narrow complex. So this is basically atrial fibrillation with fast ventricular rate. You can see V5, the R wave is quite tall. Most likely this is left ventricular hypertrophy, but there is in the V1, there is suggestion of right axis deviation. So for practical purposes, this is atrial fibrillation with fast ventricular rate, patient having right bundle branch block and left ventricle hypertrophy. Of course, you need to dig out the history of the patient and clinically examine to see whether the patient is in the heart failure or something else. And you need to control the heart rate of the patient very quickly. Normally, it should be around anything between 70 to 80 beat per minute. And of course, because this is atrial fibrillation, chances of patient having thromboembolism is quite high. So you need to anticoagulate the patient as soon as possible. Earlier, we used to use heparins, but now there are oral anticoagulants available, epexaban, edoxaban, rivaroxaban, and dabigatran. So these are oral anticoagulants, and you can start from the beginning, and you can prevent the thromboembolism in these patients. But of course, you need to control the heart rate. The best way is most likely beta blocker, or at times if beta blocker is not able to control, then you have to add digoxin as well. And of course, you have to look into the risk factor for the atrial fibrillation, why patient is having atrial fibrillation, what is the age. These days, we classify the treatment into two groups, under 65 and above 65. If patient is youngish, under 65 with low comorbidities, then we try to control the rhythm and try to give the DC cardioversion shock in order to bring the patient back into the sinus rhythm. But if patient is more than 65 years of age with comorbidities, then we simply control the rate and anticoagulate the patient and keep the patient in atrial fibrillation. It depends.
It's therapeutic talk.
Sorry, yeah, carry on.
In this situation, why we go to like anticoagulation, like rivaroxaban, but not antiplatelets like aspirin?
Yeah, actually, these are totally different pathways.
Exactly.
If you talk about the aspirin, aspirin is very antiplatelet aggregation agent. It's not anticoagulant.
Exactly. Yeah.
So yeah, there are several varieties of the antiplatelet aggregation agent these days. Aspirin is the oldest and the most trusted one. Then clopidogrel, then tricagligol or something very difficult name, and there is another one. So usually antiplatelet aggregation agents like aspirin and clopidogrel are used in cardiovascular events like ischemic heart disease or acute coronary syndrome or acute stroke, cardiovascular disease.
Mhm.
So, but because in atrial fibrillation, I will show you the ECGs later. The usually the atria are very dilated. Right atrium is very dilated, and because the rhythm activity is very chaotic, and heart may be just fibrillating, and there will be no atrial contraction, and because of that, the heart in the atrium, the blood flow is almost stagnant. There is no blood flow. Because of that, chance patients getting a clot there is very high,
Mhm.
and we need to prevent that in order to prevent the thromboembolism. So that's why we give anticoagulant rather than the antiplatelet aggregation agent. And of course, warfarin, heparin, and these Dovex, the newer agents, are directly observed, anticoagulants. These are being used. So, is that okay, or you want more anything else?
No, that's enough. Thank you.
Excellent. All right. Right. So we have talked about the narrow complex tachycardia. Now we will move on to the broad complex ones. And usually it can be ventricular tachycardia or torsade these points. And this is all because there is some abnormality or aberrant conduction from atrium to ventricle. And the because of the aberrant conduction, there will be a prolongation of the QRS complex due to delay in the activation of the ventricles, which of course, when there's a delay in activation, the QRS complex will be wider, which is more than 3 small squares or more than 1.12 second. So we will show you the ECGs of the ventricular tachycardia and torsade D points. Right. So ventricular tachycardia is basically due to reentrant circuit around the AV node. The current is basically flowing in and out of the atrioventricular node and then going into the bundle of His and of course into the ventricle. And you have to break the cycle somehow. So usually it is regular. The heartbeat is again same as supraventricular tachycardia, anything between 120 to 250 beat per minute, quite fast. P wave, again, it may be absent, it may be inverted, or it can come after the QRS complex, depending on how fast the reentrant circuit is working. As I mentioned, the QRS complex is going to be more than 0.2 second, which is 3 small squares. The shape will be quite bizarre, and rhythm, as I mentioned, is going to be regular. So this is a rhythm strip. Lead 2, you see QRS complex is all broad, but the RR or whatever, it's difficult to say whether it is RR or Q or S wave, very difficult. But of course, the QRS complex, intervals are regular, and you can make out that this is regular rhythm, broad QRS complexes, and you can hardly make out of anything else beside the ventricular tachycardia. And of course, when you examine the patient may be hemodynamically compromised, having maybe cardiogenic shock, and you have to resuscitate the patient depending on how the presentation is. Right, so this is the criteria which we have discussed already. Broad QRS complexes, QRS intervals are regular, RR interval, if you can appreciate, is going to be constant. P waves we have discussed about. Patient may be very, very unwell, and usually ventricular tachycardia indicate that the patient's heart is structurally abnormal. It could be a new coronary event. It could be an old ischemic heart event, and something superimposed causing more problem, or of course it depends on what is the comorbidity of the patient. Right, this is again ventricular tachycardia. QRS complex is broad. Here you can appreciate these are all R waves. RR interval is fairly regular, and heart rate, if you see, less than one is small square, so it's almost 200 beat per minute. And if of course if the ventricular rate is 200, then of course the heart is not having any chance to refill, and cardiac output will be compromised, and patient definitely will be hemodynamically unstable, needing resuscitation. Right, this is another ECG strip showing ventricular tachycardia. Here you can see, this is the rhythm strip. If you can see on top, there is a tiny notch on, most likely this is the T wave, and there's a tiny notch in every QRS complex. Most likely this is retrograde P wave, but difficult to say. Of course, you need to make out what is going on. Right, this is another ECG. If you see, patient is, this is the rhythm strip, lead 2. You can see patient is going into the ventricular tachycardia and coming out. So if we start from the lead 1 is upright, lead 2 is normal, lead 3 is normal. AVR is just showing the ventricular tachycardia, so unable to make out. AVF is again, AVL, AVF, both are again showing runs of ventricular tachycardia. The anterior chest leads, there are tall R waves in the normal complexes. So most likely patient is having acute coronary event or something else, difficult to say, but of course there is runs of ventricular tachycardia. And the beautiful thing here is, if you see the lead, this is lead V5. If you have a look on the lead V5, the first two complexes are narrow complex, looking like normal, preceded by P. The first QRS complex, if you see, the ST segment is normal, then followed by T wave, which is upright. In the second complex, P wave is there, QRS complex is there, and then ST segment is there, but on top of the ST segment, which where the T wave is, here the runs of ventricular tachycardia is starting. So this is so-called R on T phenomena. If you remember, I told you ST segment is basically indicating the patient is resting and repolarizing. And basically this is the refractory period where is no electrical current can follow. But if any very strong ectopic pacemaker is taking over, then it can overrule the repolarization and patient may go into ventricular tachycardia or fibrillation. So this is a beautiful example of R on T phenomena. The second in the left leaf, any of the leaf, but of course you can see very nicely the lowest one, which is lead B5. The second complex is normal, but then R on T phenomena starts and patient is developing runs of ventricular tachycardia. Right. This is another ECG. I'm just showing lots of ECG to see how every patient can present and what sort of conformation each patient may be having when they are having ventricular tachycardia. So this is again regular QRS complexes are broader and sinus, and the heart rate may be around 200 beats per minute. This is another example of ventricular tachycardia. Right, another rhythm strip. Mhm. Yeah, again, you may appreciate a tiny slurring of the ST segment. Most likely this is the P wave, but of course you need to have electro physiological mapping to find out, next to impossible by just commenting, but most likely it is retrograde P wave. And of course, heart rate is around 200 beats per minute. Again, this is.
One quickly question, if I may.
Yeah, sure.
If it irregular, does that mean that it is not VTAC, it is ventricular fibrillation?
No, ventricular fibrillation will be very irregular and will be, will not be. It will be very bizarre and different complex. It will not be regular, and
Okay.
you can just by showing. But when you have a look on the rhythm strip of the ventricular fibrillation, you will just say this is because when there is fibrillation, the electrical activity will be very bizarre. Some complexes will be taller, some will be very tiny, and maybe very irregular shape. I will show you later. So
But
you can.
can VTAC, ventricular tachycardia, come irregular?
VTech should, by definition, VTech has to be regular. But
Okay.
VTech at any stage, because of the patient is deteriorating, if the patient may be deteriorating, it can degenerate into ventricular fibrillation. That's why ventricular tachycardia is always acute emergency, and you have to uh, cardiovert the patient very quickly. Or of course, you can try some, lignocaine or xylocaine bolus as well. Sometime but usually they recommend doing, 100 joules DC cardioversion to bring the patient back to the normal sinus rhythm. And of course, IV and ABC has to be there. Dr. Fahim might have, I don't know whether Dr. Fahim has done any session with you guys, but airway, breathing, and circulation is the order of the day for this patient. And so by definition, the ventricular tachycardia is always regular.
Thank
Right.
you.
Yeah, this is again ventricular tachycardia. Yeah, so this is a very beautiful ECG. Anybody want to comment on it?
If no one, I will say the last one. But let's wait.
Yeah. So if you see these are broad complex this is broad complex, and this is fairly regular. But if you see the shape of the wave pattern is changing. Here it is the tall, and suddenly it is looking like it is twisting. So
Yeah.
this is tall, and then suddenly this is the QRS complex where suddenly the axis has changed.
Guys,
So
anyone want to take part?
sorry, say again.
I'm asking the colleagues. Anyone want to take part to say?
Yeah. Sorry, yeah. I will wait. Yeah,
Yeah.
definitely. I will appreciate if anybody can comment. Anybody want to try? All right.
Like
So
someone come in the chat, so I will say it. It is a torsadity point.
perfect.
Yeah.
Very well done. Very well done. This is torsated pointers, or torsated points, whatever people call. So, of course, whatever the axis suddenly changes, which I mentioned, I think that was the clue, changing axis. This is torsated points, and I will show you more ECGs of that. So this is torsated points. Very well done. And yeah, if you see, this is the twisting pattern. The rhythm is suddenly twisting on its axis. So this is basically torsated points. Another regular tachycardia. which is broad complex, so ventricular. So if you see, if you see the ribbon, the ordinary ribbons, and if you twist the ribbon or the party streamer, so this is the pattern, basically the torsade D point. It's very easy to see when you know, when you just think about a ribbon or party streamer, you are twisting onto that. You will notice that the pattern is changing. So basically the axis is changing on into the 360 degrees, and this is torsade D point. This is usually not very acute emergency. It could be mainly because of drug induced, or it could be because of the electrolyte imbalance, or some chronic long-term systemic illness. But that need to be, that sometime settle down on its own, or you have to just try very low dose DC cardioversion or any antiarrhythmic. Usually magnesium is the treatment of choice, IV magnesium, 1 to 2 gram. Right, so this is another torsade D points. Axis is changing rapidly, or the twisting of the ribbon. So you will simply, if you have seen 2 or 3 rhythm steps, you will not forget torsade D points basically. This is another torsade D points.
How usually the patient presents with, like, will he be normal, like awake, oriented, or will be?
Yeah, he should be alert. I have not seen any patient with the torsade D points to be hemodynamically compromised or drowsy, or in coma. They are usually alert, but they are having a feeling. They feel unwell, and there will be like palpitation, and blood pressure may or may not be low, because the uh, end of the day it is tachycardia. So cardiac end diastolic cardiac filling volumes are not very high. So
Yeah.
cardiac output is usually can be low. So you have to, of course, airway breathing circulation has to be looked into. You have to start the IV line, and then usually magnesium is the drug of choice.
Yeah.
If you
So-
if you
But
give magnesium,
it's still an emergency.
this is an emergency, but not to the extent of ventricular tachycardia or fibrillation.
Yeah.
Usually you have to, you have to have an IV access, and of course magnesium is usually very helpful. You hardly go into doing the DC cardioversion. Right.
As like hypokalemia can be one of the reasons to do
Yeah,
for.
high electrolyte imbalance, or any drugs, or any systemic. Yeah, hypokalemia is one of the reasons. You're right.
So we have to collect it also.
Yeah. Of course, you have to do the urgent urea electric. Sorry, the electrolytes check, and if they are up, and even magnesium can do that. Magnesium as well. That's why we give magnesium usually.
Yeah. Center.
Excellent. All right. So yeah, this is so any you see, this is basically, this is the lead two. You can see the rhythm is uh, the basic rhythm is sinus. The P wave is there, normal narrow complex. QRS complexes. ST segment is normal. T wave is upright. But in between there are broadcast complexes, 3 or 4 QRS complexes. So 1, 2, 3, 4. This is ventricular. This is the premature ventricular contraction. Premature ventricular contractions. There are 4 in row. In the second run, there are 3. So if there are 2 premature ventricular contractions are coming simultaneously, 2 beats, then they call it run of ventricular tachycardia. If it is 3, between 3 to 5, it still is run of ventricular tachycardia, but there's a specific term which sometimes people use, not always. It's called salvos. So runs of 3 or more than, the runs of 3 to 5 ventricular beats is called salvos, but you can still call runs of ventricular tachycardia. So this is, this is the term which sometimes used, but it's not being used too often. But of course, in the medical exams, especially in the medical exams, you can, in the final exams, or the if the interns are going through some assessment, this is one of the favorite choice for the medical specialists. So this is salvos, the runs of ventricular tachycardia, beats anything between 3 to 5 beats is salvos. More than that is, of course, ventricular tachycardia. So this is again isolated runs of 3 to 5 premature ventricular contractions is called salvos. Right. So, oh, I don't know how this came in between. Anyway, this is a junction rhythm. Yeah. Anybody want to comment on this ECG? Of course, if you read the explanation on top, it is there, but I don't know. I should have highlighted that explanation. But this is a very this is a beautiful example of a of a congenital heart, one of the congenital heart diseases. Anyway, so right. So if you see on top, it says sinus rhythm, Wolff-Parkinson-White syndrome or WBW syndrome. It says abnormal ECGs. So anyway, that is right. So if you go into the P wave is there, but the PR interval is very, very narrow. You can see it, as I mentioned, it should be 3 to 5 small square. If it need to be in order to be normal PR interval, it need to be 3 to 5 small square, which is 0.0, 0.12 to 0.2 second. But here it is hardly 2 small squares or 0.2, 0.8 second. There is initial slurring of the QRS complex, and there is some, yeah. So this is called delta wave, and this is because of the presence of an accessory electrical channel or bundle between the atrium and ventricle, and is called bundle of Kent. There can be various presented. There are 4 types, but of course I don't have time to discuss all the 4 types. But for practical purpose, this is delta wave, and patient is having Wolff-Parkinson-White syndrome. So by definition, there will be narrow QRS. Sorry. There will be narrow PR interval followed by initial slurring of the QRS complex, which is called delta wave. So this is for practical purposes WPW syndrome, and the patients can present with tachyarrhythmias, supraventricular tachycardias, as well as atrial fibrillation. So you have to assess the patient appropriately, and of course, patient need electrophysiological activities, and then treated accordingly. Usually, patient need antiarrhythmic medication to control, and beta blockers are contraindicated. But right. So this is WPW syndrome, shortened PR interval, delta wave, which is I mentioned initial slurring of the upstroke of the QRS complex. QRS complex seems widened, but because of the presence of the delta wave, but in fact it is not broad complex. If you see in this ECG previous one, if you see on the baseline, you can see the QRS complex seems widened, but if you see on the top, it is not widened QRS complex. So this is pseudo QRS complex broadening, but in fact it is not there. STD changes may be there. So let's talk about atrial fibrillation, which I showed a couple of ECGs before. Right, so this is the normal electrical activity in the heart. So this is SA node, then the 3 bundles in the atrium conducting current from the SA node to the atrium, then AV node, then bundle of His and the bundle branches. But in the disease heart, where there is dilatation of the atrium and there is distortion of the electrical wiring in the atrium, there will be re-entrance electric currents in various parts, which may cross over to both the atrium and then try to pass through the AV node and go into the ventricle. And if you remember, we talked about the depolarization of the different part of the cardiac muscles, including the electrical conducting system, and then repolarization, which is basically the resting phase, and there will be no current passing through these tissues at that particular moment. So there can be refractive periods. So because of the AV node is encountering lots of pacemaker into the atrium, which all try to pass through the AV node into the ventricle, and it can at times get fatigued, and could be because of the refractive period. Not all the electric current coming onto the AV node will be transferred to the or transmitted to the ventricle. So if the pace, pace if the ectopic pacemaker is creating current strong enough, it may pass. So if you see here in the normal heart, it is normal sinus rhythm, but on the right side, the strip is showing this QRS complexes are there, but they are irregular. Their RR interval are irregular. So, and there is hardly any P wave, but there is some fibrillation wave present at the baseline. So this is the abnormal electrical pathways in the atrium taking over the role of pacemaker and causing chaotic electrical activity resulting in atrial fibrillation. And because there is chaotic electrical activity in the right atrium, the atrial systole is almost lost, and there will be there will be no contractility within the atrium, and the blood flow will be stagnant, causing clot or thrombus formation, and that's why we have to give the anticoagulant from the beginning. Right. So you see the QRS complexes are almost within the normal limit, narrow complex, and in the baseline you hardly see any P wave throughout, and there are tiny fibrillation waves which are tiny like vibrations at the baseline, and rhythm is irregular. So for practical purposes, this is atrial fibrillation. Can anybody comment if you don't have the ECG, you are examining the patient? Can you make out the patient is having atrial fibrillation, but just by clinical examination? Is it possible? Any comment from anybody?
I think that the irregularity of the pulse,
Excellent. Well done. Yeah, there is something else as well.
uh, maybe by stethoscope, if we listen to the heart, it will be like as the
Exactly.
atrium will not like uh, compress normally, so it will be just flatter.
Yeah, to some extent you are very right. There's a term called pulse deficit. As I was mentioning, not all the not all the electrical currents are transmitting into the ventricle. So if you listen to the heart, there will be faster heart rate, but when you feel the pulse, the radial pulse, the pulse rate will be slow, but heart rate will be fast. So normally, if there is atrial fibrillation, the pulse deficit will be more than 30 beat when you listen to the heart and feel the pulse. So this is called a pulse deficit, and this is an indicative of atrial fibrillation on clinical examination without seeing the ECG. So you may come across when I was doing my final year exams. Actually, I came across one patient like that, and I failed because I didn't know that pulse deficit that particular time. But of course, I passed the exam. But that particular station, it was a short station, I failed that basically because I could not comment on that. Right.
So
So this is atrial fibrillation.
hope we will have it, as we know it already.
Well, you need to be smart enough to pick it up, isn't it?
Yeah.
It's difficult, but of course, it is possible. If you think about, if you're feeling the pulse and heart rate, you're auscultating the heart with the stethoscope and feeling the pulse same time, you will easily appreciate that.
Yeah.
And of course, when there was no ECG machine, even then, people were atrial fibrillation was an entity, and people were treating the patients with digoxin those days as well. Maybe one. There was a I think European cardiologist. I forgot his name. Basically, he invented that term pulse deficit that particular moment, but I can't recall the name of cardiologist. Anyway, so as we just mentioned, due to multiple reentrant wave lefts conducted between the atria, and then pulses are formed, which are unpredictable and chaotic. And of course, they all try to pass through the AV node, but AV node may be refractory or fatigued already, so it will not allow all the current to flow through. So that's why the rhythm is irregular. Right. So that I already mentioned. Right. So we have discussed about atrial fibrillation and atrial flutter. There you will see sawtooth appearance. The heart rate is again very rapid, but usually the rhythm is regular. In atrial fibrillation, there will be no wave, or there will be fibrillation waves, which will be bizarre. P waves, rhythm is irregular. It can be slow. It can be fast ventricular rate. The ECG I showed was fast ventricular rate, and it can be normal heart rate, anything between 60 to 90 beat per minute. So it all depends on how the patient is presenting at that particular moment. Right. So this is the saw, which is the old equipment to cut the wood, and you can see this blade is showing sawtooth. So that is basically you will come across in patient with atrial flutter. Right. So this is a classical rhythm strip showing atrial flutter. There is no P wave. The RR interval is regular. The PP or sawtooth, the interval is also regular. So basically, this is atrial flutter, and this is regular heartbeat. So it is deviated from the normal sinus rhythm. There are no P wave. Instead, you are observing flutter wave, which is sawtooth appearance. The heart rate is usually very fast, anything between 200 to 350 beats per minute, depending on how the AV node is behaving. If the AV node is allowing all the beats to pass through, of course, the heart rate will be very fast, but the AV node is getting fatigued or having refracting period, then there will be block at the level of AV junction or AV node. So only some pulses conduct through the AV node, usually every other pulse, which we'll see in a minute. Yeah, right. So atrial flutter can be regular, it can be irregular in one rhythm strip. It all depends on how the AV node is behaving. It can be having refractive period, so it will not allow every atrial activity to pass through it and go into the ventricle. It can be having refractive period. So if you see here in this initial rhythm strip, there are two sawtooth waves followed by one QRS complex. So this is 2:1 block. Here, if you see, there are four sawtooth followed by one QRS complex. Here, there are three. So you can just appreciate what sort of AV block patient is having in atrial flutter. So this is atrial flutter with variable blocks. Right. So this is again, if you see, this is heart rate is quite fast. There are two squares between the RR wave. So 300 divided by 2 will be 150 beat per minute. And if you there is single sawtooth wave followed by QRS complex. So this is basically atrial regular tachycardia indicating atrial flutter with 2:1 block. Sorry, I just wanted to comment on, yeah, this cardiac axis is normal, and in the V1, in the anterior chest lead, the progression of the R wave is perfectly within normal limits. So there is no other ECG abnormalities indicating patient is having some other cardiac problem at that particular moment. So this is just atrial flutter. Right, this is another ECG showing atrial flutter, 4:1 block. This is regular. And if you see lead 1, the thumb is upright. AVF, the uh, thumb is yeah. Basically, the QRS complex is mainly downward. So this is left axis deviation. And if you look into the anterior chest leads, there is RSR pattern or M pattern, indicating that patient is having right bundle branch block. So this is right bundle branch block with left axis deviation, and the rhythm is atrial flutter with 4:1 AV block. Right, this is another ECG. The axis is normal. There is a tall R wave in the V1, V2. It could be right ventricular hypertrophy, or it could be old posterior MI, difficult to say. But if you have a look on the rhythm is stiff lead 2, the RR interval is normal, and this is 5:1 AV plot with atrial flutter. Right, this is again 2:1 block with atrial flutter, and the rest of the ECG changes are, the rest of the ECG is within acceptable range. This is another atrial flutter, and if you have a look on the anterior chest lead, again there is tiny R followed by S, then another R. So this is right axis right bundle branch block, and the axis is normal, and of course this is atrial flutter. What is the time now?
We have a question for the atrial flutter treatment. Can we
Yeah,
use adenosine in the treatment of atrial flutter?
adenosine.
Adenosine, yes.
No, adenosine is basically for, adenosine basically what it does is it increases the refractive period of the AV node. So basically it is making the AV node more refractory to the electrical current generated in the atrium. But here there is already AV block, so there is no need for the for the adenosine to be used. Here the only thing is if the heart rate is very fast, like 1:1, like 300 or more than 300, then you need to use very low dose DC cardioversion to convert the to increase the heart block. Sometimes it may come back into the sinus rhythm, but adenosine cannot be used in this rhythm. This is only adenosine is only basically reserved for the supraventricular tachycardia.
Great, thank you.
All right. Okay. So this is we have discussed. This is another atrial flutter. Right. So yeah. So there is already explanation about the interpretation of the ECGs on the top. So the rhythm is step lead 2. RR waves are RR intervals are very, very irregular, and you can see the fibrillation wave at the baseline. The lead 1 is upright, lead AVF is very difficult to make, but most likely it is the major deflection is downward, so this is left axis deviation. The anterior chest leads are looking okayish to me. So basically this is atrial fibrillation. Now, one thing, how you're going to calculate the heart rate in atrial fibrillation, because we were talking about that you need to calculate the heart rate by number of square between the RR waves and then divide the 300 by them. But here the RR interval is not regular. So you have to take the average. What they say is you need to take a long rhythm strip, lead lead 2, and you need to calculate, like if I mentioned to you guys that the big square is 0.2 second. So 5 squares will be 1 second. So you need to look into the 6-second strip and count the number of R wave in that, and then multiply by 10, making it 60 second or 1 minute. So you have to take 6-second strip, count the number of R waves, and then multiply it by 6, making it for the 60 second, and that will be the heart rate. So if you see into that, so 6 second will be 5 into 6, 30 squares. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4, 5. So this is the 10. So these are the from here to here. If you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 70 into 10 will be 170. So heart rate is almost 170 beat per minute. So this patient is having fast ventricular rate, and you have to control the heart rate very quickly. If the patient is hemodynamically unstable, you have to just try low dose DC cardioversion. Right. So this is another atrial fibrillation, and rhythm is normal. There is RSR in the lead V1, indicating right bundle branch block. Rest of the ECG is looking okay. Heart rate is quite fast again. You can use the 6-second strip and then divide by 10 to calculate the heart rate. Right, this is another atrial fibrillation. And in this ECG, again, if you see this in lead V1 and V2. No, so the V2 is not there. It's difficult to make out, but of course, there are T wave inversions in lead V1 and V2. So this is another atrial fibrillation. Atrial fibrillation with the rest of the ECGs are. There is one beautiful phenomenon in this ECG here. If you look into the, for example, lead V1, you see one beat, one QRS complex is larger, the in depth, and the other one is not that deep. So every other beat is, one beat is strong, one beat is small. This phenomenon is called electrical alternance. What happens is, because of the heart failure or left ventricular diastolic dysfunction, heart during the systole, the ventricles are contracting very strongly, and but then getting exhausted. So second beat, they are again having the systole, but not that strong. That's why the electrical current is not that deep. So this phenomenon is called electrical alternance. One beat will be having deep, bigger QRS complex. The second beat will be a smaller QRS complex, indicating left ventricular systolic dysfunction. So you can see it here, but it was more clear here in the lead V1. So that I thought I will just mention about that. Right. So this is again atrial fibrillation. Yeah, this is atrial. This is, where is lead 2? This is lead 2. Yeah, atrial fibrillation. But there is some suggestion of the, in lead V1, there is some suggestion of the flutter and fibrillation. So this is basically combined flutter and fibrillation. And more than 50% of patients, they will present combined atrial fibrillation and flutter, because they are the, they are basically arrhythmia showing the same spectrum from the atrium. Right, this is again atrial fibrillation. Yeah, this is a very good ECG. If you see lead V1, you can see the flutter waves. And if you have a look on the QRS complexes, they are broad QRS complexes. The T wave is in the opposite direction of the major QRS deflection. If you have a look in the anterior chest lead, there is broad QRS complex, broad bizarre, lead V1, V2. This is basically left atrial fibrillation with left bundle branch block. This is a very good ECG. So just try to see this ECG.
Sorry, doctor, we don't hear you. We can't hear you, Dr. Ali. Sorry. No voice from your side. I don't know if you hear me, but we don't hear you. Sorry, doctor. أعتقد أكون مشكلة صارت يم الدكتور علي بالإنترنت. ثواني وتنحل. إن شاء الله ما تعبتوا. هسه لو دكتورة مريم موجودة كان كملت مكان دكتورة علي. عاشت ايدكم زميلتنا طيبة. ودكتور علي ممتاز شرحه، بس ما يخلينا نحمى، يعني يحكي شو يقولوا، ما يصيح، ما هادي. المحاضرة الهادئة واحد ينام بيها يعني. الله يسعدكم. هو زين وصلنا احنا 8 باقين.
Hello.
Welcome back, Dr. Ali.
Yeah, sorry. I think there was some issues with the Wi-Fi connection. So yeah, I'm just trying to finish, those ECG. So could you hear this one, which I'm showing right now?
Yes.
So this is the atrial fibrillation with the left ventral branch block. Right, and okay, so this is another left atrial fibrillation with normal looking ECG. This is this is atrial fibrillation, and the axis is normal. The anterior chest lead, if you see, there is tiny RSR pattern, which is the QRS complex is not broad. So this is basically partial right bundle branch block. And if you see onto the lateral chest leads, which are V4, V5, you can see some asymmetric T-wave inversion. This is a beautiful sign we sometimes call El Salvador mustache sign, which I will explain perhaps next week, and this is basically due to the use of the digoxin in this patient. This is not digoxin toxicity, but this is the digoxin effect on the ECG. Usually it affects the ST segment, and there will be ST segment inversion. Sometimes it is called reverse tick sign. If you see, it's like a reverse tick sign. So this is reverse tick. And so this is a beautiful digoxin effect on the ECG. Right, this is atrial fibrillation, and if you can see, there is some suggestion of there is in lead 2, lead 3, and lead AVF. There are broad deep Q waves. So this is basically inferior wall myocardial infarction, which is old because the T wave is upright, and this is atrial fibrillation, and there are some T wave inversions in the lateral leads V5 and V6, which most probably could be left ventricular hypertrophy with the strain pattern, but all depends on how the patient is presenting with the comorbidities.
So this pathological Q wave, it's a like sign of history of MIs. Yeah, right.
Yeah, the patient maybe, some the inferior wall MI, because it's a small area. Is inferior wall is not very big area of the heart. Sometimes patient may not never presented with any chest pain as well. There can be, I've seen lots of patients with old inferior wall myocardial infarction in the ECG, but patient never presented with any complaints of that nature. So may or may not be presenting with, but this is not the acute myocardial infarction. This is not acute coronary event. This is old. So it is definitely there, but this T wave inversions, you need to look into why they are T wave inversion in the lateral leads. It could be left ventricular hypertrophy because of the hypertension. It could be some other thing, but of course, presentation of the patient is important. But ECG, of course, it is suggestive of old Q wave myocardial infarction. Right. So this is another sinus atrial fibrillation with fast ventricular rate. And you can see the electrical alternance in this ECG again, which is a sign of left ventricular systolic dysfunction. Another ECG with fast ventricular rate, atrial fibrillation. The axis is left axis, and rest of the ECG is perfectly within normal limit. This is again a combination of flutter and fibrillation, and it's difficult to make out in the lead V1 what is happening, but it could be right ventricular hypertrophy, or it could be cardiomyopathy, because there is some suggestion of tall R waves in the lateral chest leads as well. So it's difficult to say, but of course it is atrial fibrillation with fibrillation, atrial flutter and fibrillation, and there are some changes in the anterior chest leads, which the patient needs further investigation in the form of echo. If the echo is showing some hypertrophy, then of course patient may need cardiac MRI. Sometime it could be because of the hypertrophic cardiomyopathy, because lead V1 and V2, V3, they are sometimes called the septal leads as well, lead 2 and 3. It is sitting in lead 2 and 3 are sitting on a ventricular septal area. So it could be septal hypertrophy indicating hypertrophic cardiomyopathy, but difficult to say just on ECG. Right, so this is another. Okay, so this is what is going on here. Right, this is atrial fibrillation with irregular rhythm, but RSR pattern is there, indicating in the lead V1, indicating right bundle branch block. The axis is left axis. Of course, we need to dig out what is going on, but comorbidity of the patient is important. The ECG is atrial fibrillation with right bundle branch block and left axis deviation. Oh, sorry, right axis. I beg your pardon. Yeah, I already said, yeah, this is right axis. Right. I think we will call it a day today. We will discuss with hard block and rest of the bits next, but next maybe a bit prolonged because I think it may be more than 90-minute session next time. Today was 90 minutes.
Doctor, can you go back for the last ECG, please?
Yeah, sure. Oh, I think, yeah, I'm going back. Yeah, just give me, yeah, this one.
So it is a left axis.
It is, yeah, if you see into the lead V1 and lead AVF, if you remember the thumb sign, if the lead 1 is upright and lead AVF is down. So basically the thumbs are in opposite direction. So this is left axis deviation, broadly speaking. And patient is having right bundle branch block as well.
Yeah.
And the rhythm is atrial fibrillation. So basically it's atrial fibrillation with right bundle branch block and left axis deviation. Most likely it is bifascicular block, which we'll try to discuss next time.
Yeah.
But this is a very good ECG. Are you recording this session or
Yes.
you're not recording?
We do recording.
Yeah, then that's fine. Then it will help. Yeah, that will help a lot because they can have a look on the ECG and they can remind themselves of changes.
Exactly. Yeah.
Any question or otherwise we just finish it off and inshallah we will do this last session on coming Saturday at 6 o'clock again. Or if you want to change time, it's up to you really.
Inshallah, it will be okay. Like 6 p.m. UK time, 9 p.m. Iraq time, Baghdad time, because they will mix. If they have 6 p.m.
So, right. Okay.
Yeah, guys, any question? So the first question is after thanking you, Dr. Ali, for the amazing effort, the treatment of the torsodity point or torsodity point. Can you please repeat it as you already mentioned, but can you just
yeah, the torsodity point is, as you're rightly pointing out, it could be because of the electrolyte abnormalities, and usually the treatment of choice in the emergency setting, in the accident and emergency or emergency room, whatever you call, Tawari or whatever you call it. I think it's called Tawari in Arabic, isn't it?
Yeah, ER, emergency room. Yeah.
Yeah, emergency room. So basically, of course, the airway breathing circulation is the most important thing. You have to have an IV access. And when the ECG is done, you see torsity point. The first thing you have to do is usually IV magnesium 1 to 2 gram stat. Just go stat. No need for the dilution. Without dilution, just go into IV access and give that, and more than 99% the patient is usually reverted back to the normal sinus rhythm if it is because of the electrolyte abnormality. If there is something else, then of course it may not. Then you have to try low dose DC cardioversion, and that's what basically the treatment is. But IV magnesium, I have not seen anybody not coming back to normal sinus rhythm basically, unless there is some other structural cardiac abnormality.
Yeah. Another question from our collective. Can you please repeat the explaining for white Parkinson-Wolf syndrome and show the example with the delta wave?
Yeah, I'm going to show 3-4 slides again next week. But let me check. Let me go back if I can find quickly WW syndrome. Okay. So basically the PR interval is shortened PR interval, less than 3 small square. There will be initial slurring of the QRS complex, the initial slurring of the first component of the QRS complex. And because of that, there will be pseudo picture of looking like QRS complex is, yeah, this is D1, yeah. So if you see here, if you see where is lead 2, I can't see. There's no rhythm strip. So no, the lead one is rhythm strip. Yeah, this is the lead two. If you see here, this is the P wave, which is normal shape, but PR interval is shortened, and there is the initial slurring. It is more clear on the
Lead
if
one,
you
I
can.
think, very clear in lead one.
Yeah, lead one. Yeah, if you see, there is initial slurring of the up upstroke of the R wave, and PR interval is very shortened. If I compare it with some other ECG, yeah, if you have a look here, this for example, lead one, same lead. If you see there is no uh, slurring of the upstroke of the QRS complex. There is no slurring of QRS complex, and if you compare it here, you will find PR interval is very shortened. There is initial slurring of the upstroke of the R wave, and this is basically delta wave. But I
Yeah.
will show you more ECGs next week, inshallah.
Is it clear, طيبة, or like I will just say it in Arabic. الكيو ار اس يعني بعد البي ما تصعد قبل يصير اكو ويف صغيره كلش. هي عاده شو تصير؟ يصير اكو ليك او حزمه اضافيه تعبر من الاتريوم للفنتركل، فتعبر الاشاره بحيث ما يصير الباوز او الاستراحه ما بين البي والكيو ار اس. فقبل هاي تعبر فراسا يصير صعود. شوفيني كحركه او مثل شلون نقول صعده اضافيه قبل الار. هي هاي اللي نعتبرها الدلتا ويف، اللي هي علامه وايد دبليو بي دبليو، وايت باركنسون وولف syndrome. Sorry, Dr. Ali. Yeah, sorry, I just give it briefly.
No, that's fine. That's fine. Is it clear for her, or should I try more?
I don't know. طيبة, is it, if it's not clear, please comment. If it's clear, also say it's clear.
In either case, I'm going to show you more ECGs next week, because this came in between, but there will be 4 or 5 more ECGs next week, inshallah.
Yeah, inshallah. Thank you.
All right. Look after all of you yourself, and inshallah, wish you all the best in your future endeavors. And I will talk to you guys on Saturday again, inshallah.
Inshallah. Thanks a lot, Dr. Ali. And see you, inshallah, next Saturday, the same time. All the best for all the colleagues. Please stay safe, wear mask, and
I agree with you. You're right. Inshallah, everything will be fine. You look after yourself, and fi amanillah, inshallah.
Fi amanillah. Thank you.